Thank you. So good morning. This is Senate Health and Welfare. It is January 26th. And this morning we're going to look at, go back and look at S98, which is the Green Mountain Care Board regulatory authority over prescription drug costs, a bill that we have in the committee. And Jen, you're going to give us a high level overview of that. At 10:30, we're going to go down to meet with agriculture on a section of S197 that relates to pesticides and agricultural issues. So we'll hear testimony from some folks down there. And I think that's really it. The other thing is we did get some nominations. And so I think, unless I hear differently, we'll appoint our vice chair as the leader. Okay, that's great.
I'm ready.
Okay, you're ready. All right. So we'll do that. So thank you all. We have witnesses up on Zoom. We'll hear from them in a minute. So Jen, here we are.
Yes, here we are. Jennifer Kirby, Office of Legislative Counsel. So this is S98, an act relating to Green Mountain Care Board authority over prescription drug costs. I think we did a detailed walkthrough a while ago.
Yeah.
This would create a new subchapter on prescription drug affordability, direct the Green Mountain Care Board to identify high-cost prescription drugs for potential review of their affordability, and it sets forth some criteria for identifying those drugs. Then the board would determine for each drug it identified whether to conduct a full affordability review for that drug. It's got some information about what that process would look like. And then if the board finds that a particular prescription drug that it reviewed is likely to lead to affordability challenges, it allows the board to establish, or directs the board to establish, an upper payment limit for that drug. And there's a lot more information about what that process looks like, but basically the upper payment limit would be the maximum amount that providers who dispense or administer prescription drugs would bill all of the payers who you have regulatory authority over to require them to participate, how much they could be billed for those prescription drugs. The bill creates a prescription drug affordability stakeholder council to advise on the prescription drug affordability review. Section 2 of the bill amends the Green Mountain Care Board's duties to include this new prescription drug affordability role. Section 3 is just some implementation provisions for starting up that stakeholder advisory council. Section 4 requires the Green Mountain Care Board to submit a report on the operation of the generic drug market in the U.S. and in Vermont. Section 5 repeals an existing provision on prescription drug cost transparency. It has more of this work being done at the Attorney General's office. And then the act has an effective date that is already outdated, so you need to at least update that.
Good. And just to let folks know, today we're getting some baseline testimony on people who know about the operation of these advisory boards in other states where they've started to happen, to give us some information about that. And then just some beginning testimony. And obviously we're going to have to hear from a lot of people who have interest in this, have already received lots of requests to comment. So this is a first look with testimony. Any questions for Jen? Good, thank you. Okay. All right. So I'm going to go to Colin Robinson, who's here, and from the Vermont National Education Association. And Colin, you're very interested in this bill, and so why don't you give us your testimony?
Absolutely. Thanks, Madam Chair. First of all, I just want to acknowledge, I feel like I'm sitting in the Education Committee, you know, past and present. It's wonderful to see all the familiar faces. So for the record, Colin Robinson, Vermont NEA. So I want to start by saying folks might be wondering, why is the union that represents public school employees interested in healthcare reform efforts? Vermont NEA has been involved in advocating for broad systemic healthcare reform to make it more affordable for all Vermonters for over 30 years, including the creation of Catamount Healthcare, the expansion of other programs. And so there's a through line there because our members are working every single day with youth, kids, and families to make sure they're able to access their learning. And of course, if they can't have high quality, affordable healthcare, they're not able to do that. Furthermore, school employees comprise a very significant population of folks who are receiving healthcare in Vermont. And so the trends that are impacting all Vermonters when it comes to healthcare costs are impacting school employees and school employers, right? So one of the reasons why we are excited about S98 and giving the Green Mountain Care Board the authority to look at prescription drug costs is because we recognize that other states are starting to dig into this, that prescription drug costs are a major driver in the cost of healthcare for school employees and their families, as well as all Vermonters. And so being able to access high quality, affordable medication when you need it at a price you can afford is obviously going to impact one's overall health. I wanted to punctuate this need with a little snapshot into the pool that covers school employees. VHI, the Vermont Education Health Initiative, is a healthcare trust that's been co-administrated between the Vermont School Board's Insurance Trust and Vermont NEA since the early 1990s. The co-trust administrators, Bobby Joe Sauls from Visbit and Mark Cage from Vermont NEA, provided some detailed testimony to the House Education Committee the first week of January. And I linked to that in the testimony I submitted to Kiki. But they specifically pulled out some cost trends related to pharmaceuticals that I think really illustrates the need for, as a matter of state policy impacting all Vermonters' access to healthcare, our need to have a comprehensive systematic solution to begin to address this and address this in ways that we haven't done recently. So if you'll bear with me while I read through some of those points, and the specific details are linked to in my testimony. So for VHI is a pool that covers 35,000 Vermonters. That's educators, from administrators to bus drivers and school employees in between, and their dependents. 20% of VHI's claim spend is on prescription drugs. And when you drill down into that, just for the first 9 months of 2023, you saw significant increases. So VHI incurred a gross prescription drug cost of $55.1 million compared to $46.2 million for the same period in 2022. So that's a $9 million increase in 1 year just on prescription drug costs. Overall prescription drug cost inflationary trend is 22.5%. Within specialty drugs, it's 20.6%. Non-specialty drugs is 24.9%. Specialty medications. Oh yes.
Are these Vermont numbers or not?
These are Vermont numbers. This
Yeah,
is specific. This is specific to the pool that covers public school employees in Vermont, which is one of the largest pools outside of Medicaid and the exchange that exists in the state. It's also a pool that works. VHI contracts with Blue Cross Blue Shield to administer it, and VHI and Blue Cross are constantly working to try and figure out new and innovative ways. However, there are only so many tools available, and we think S98 brings another tool into that policy solution. So when it comes to specialty medications, this is where we see some really significant cost drivers and really highlights the challenges. Specialty medications account for 56.1% of VHI's total prescription drug spend. In the first 9 months of 2023, the specialty medications cost over $30 million. even though that was only providing, there were only 829 VHI beneficiaries receiving that. So we spent over $30 million in prescription drug costs on 829 individuals out of a pool of 35,000 or 34,000. This group of patients represents 3.2% of the total patient count. So the average gross cost per patient on specialty medications was over $37,000. And you dive even further, and just 246 VHI patients need medications that cost $50,000 or more. But in aggregate, their claims represent 42% of VHI's gross costs. So these really high-priced specialty medications are driving a significant growth in VHI's pool, which is a mirror of the trends across markets. Conversely, remember we talked about 34,000 covered lives. Just over nearly 22,000 VHI patients needed medications that cost between $1 and less than $1,000, with a gross per patient cost of $150 to $5. So the vast majority of folks are, using relatively minimal amounts. This is all in the context. VHI and Blue Cross Blue Shield work together with an entity called Remedy Analytics to really try and capture and get a handle on some of these RX costs over the past, I want to say 8 to 10 years. And they've done that by looking at PBMs and where the contracts can be renegotiated and save millions and millions and millions of dollars. But this is still where we are right now. So it's for those reasons that we think addressing this in a systemic way, it's a systems problem. VHI is doing what they can for school employees and school districts, but these are trend lines that are not unique to VHI. They're trend lines that are impacting students and families and their ability to access high quality health care. And we think S98 giving the Green Mountain Care Board the authority to dig into these prescription drug costs and make sure that Vermonters are able to access the medication they need at a price they can afford is really important. So with that,
Thank you.
happy to answer
You've
questions.
done a significant amount of work in bringing the data to us and helping us understand this. This is great. Thank you. Questions?
Credit goes to Bobby Joe Sauls and Mark H.
Okay.
For those specifics.
Terrific. Okay, let's say thank you, please.
Yes.
Yes, and you've been working with Blue Cross and Blue Shield, and that's another thank you for that. Any questions?
Just one comment, because I didn't hear you say this, but this also is the cost of healthcare is a driver in our school budgets.
That's how we started.
Oh,
That's how we started.
Made that
Yeah,
link.
totally.
It's a
Missed
cost,
that,
it's a
sorry.
cost, yeah, but Senator Hardy's right, it's a cost driver, not just in schools, but in every organization.
Yeah.
Anyone using drugs, it's a huge cost driver.
Sorry, Colin.
No.
I don't really listen, obviously.
Well,
Yes.
I quoted lots of numbers, so it's easy to get.
No, but thanks for your testimony and for the
Yeah.
link in, it's great.
And I would say if folks are interested in learning more about VHI, Bobby Joe and Mark went into significant comprehensive, there's some pie charts in there, it's 5 pages of testimonies. They only pulled out the specific points related to RX.
We'll all read that.
Sure.
Other questions? Okay, so there's an incentive for the education committee to take a look at it, right?
Yeah,
Saves money.
Yeah,
it's on the radar.
Is it really? Oh, that's good. Okay,
Absolutely.
thank you.
great. Thank you,
We're-
Senators.
We're gonna move on to some of our expert witnesses who are on Zoom with us, and they're, so Jane, you're here. Jane Horvath. There you are. There, hi, welcome. It's good to see you again. And we're glad that you're here. Are you gonna go first and then Mariana?
However you would prefer it, Senator.
Hold on a minute, we need to increase the volume because we can hardly hear you. Did you do it? Okay, try again.
said, however you would prefer to do it. I'm sure Mariana doesn't care either, so your preference.
We'll begin with you and then we'll move on to Mariana, and if it gets into conversation, that's just fine. So we do appreciate your being here, and would ask you to introduce yourself for the record. And then we do have some testimony from you, and we'll follow along with your testimony. I'm sure there will be questions at the end based on what you know about experiences across the country and so on. So thank you.
Yes, and so you do have my testimony, and I think it would be great to work a lot with questions, because this is just a super complicated area, rather than my talking at you this whole time. I just want to stress a couple things, which is, and it's in my testimony, but in summary, like this whole market segment.
I'm going to interrupt. Sorry to do this. You need to introduce yourself for the record. Just state your name.
I do apologize. So my name is Jane Horvath. I run a very small consulting shop, Horvath Health Policy. I have money from different foundations, grants to do work with states specifically on prescription drug cost containment issues. And I have been focusing these last several years on this whole concept of prescription drug affordability boards and statewide rate setting for the cost of prescription products. So that's me, and I have a long background that is in my testimony on this issue. But I just wanted to sort of lay the groundwork, which is to say that there is like so much dysfunction in this part of the US economy, the pharmaceutical market. And when you talk to any part of that economy, so you talk to manufacturers, you talk to insurers, you talk to pharmacists, pharmacy benefit managers, and they all have a reason why there's a problem, and it's someone else. And the thing is that they are all correct, because the problems, we've started with high prices, and then sort of all of the stuff that is not working very well has arisen to address the high prices. And the only part of the market that sort of doesn't have a business plan around pharmaceuticals and how to either fend off the high prices or make money on the high prices is the consumer. And so trying to pull the system apart and figure out how you get to the consumer, how you rearrange everything so that the consumer can benefit actually and be able to afford prescription drugs. Requires a lot of work. It requires sort of adjustment in a lot of different places in the system, basically. You can't just fix one thing just because of how the market has come to operate, basically. So I really wanted to just lay that out, and to, you know, if it feels very confusing, it is because it's very confusing. It's a very complicated market. And then I know you wanted to hear about what other states are doing. They're doing a variety of different things. So with regard to prescription drug affordability boards specifically, we have 3 states now, Minnesota, Colorado, and Washington, that have created their prescription drug affordability boards, and the boards have authority to do rate setting for certain high-cost drugs, and that rate setting would be statewide. And what that means is that to the extent that a board decides what the consumer will pay, what will be paid in the state of, say, Colorado or Washington, the product comes in through the wholesalers, as it normally does. This whole thing uses the existing supply chain, but all the transactions around that product are at no more than the upper payment limit, basically. So Colorado is the furthest along. They have already done a cost review on one product and decided that it's an expensive product, but it doesn't necessarily mean that it creates an affordability problem for consumers. And so they put that aside. They've made their decision, they've done their analysis, and now they are looking at other products. Washington State's has really, they were created several years ago, but they've really only started working now this winter, basically. And I think we're going to see a lot of productivity and a lot of work coming out of Washington State's Prescription Affordability Board soon, because they are trying to make up for lost time, and they seem to be quite active, but they have just started. And then we have Minnesota, who just enacted Prescription Drug Affordability Board this summer. They are in the process of putting their board together. And again, they have statewide upper payment authority. And Maryland has been in existence now for several years. Their remit at the moment is to create upper payment limits for state and local government purchasers and payers. And they are creating a plan to do that right now. And there's just been legislation introduced this session in Maryland to have that board proceed with statewide upper payment limits, which is actually easier. It's easier to work with a whole statewide system in terms of being able to get a lower cost product to the consumer at the point of service. It's harder if you're just dealing with a piece of the state population. And we can talk about why that is. But so Maryland is, some members in Maryland are realizing this and would just like the board to go statewide because they think it'll be more productive more quickly. Oregon has a Prescription Drug Affordability Board, and they are in the process of producing a report back to the legislature on how they would implement statewide rate setting for prescription drugs. And then we have New Hampshire and Maine. They have prescription boards also, and the remit of both of those boards is simply state government. And I think Michigan and Illinois are debating this session now, creation of prescription drug affordability boards, and those boards would have statewide rate setting authority. And Mariana is going to come behind me and correct me where I'm wrong or if I have missed anyone, but I don't think I have. The other thing I just wanted to say, part of what makes this so complicated is there are many players in the system, and people have figured out a way again to fend off high prices or to make money off of high prices, help to fund the services that they provide that they are not otherwise compensated for, or if they feel like their services are not paid for enough to provide the services, then this extra stream of income helps provide those services. So you'll hear from many people during the course of this debate. And I just wanted to set the table that, there's a lot of interest coming at this from many, many different angles. And I think that's really all I need to say, and I'm hoping we can get into a lot more with questions.
Thank you. And there are questions, and I see in your testimony that you've gone through some of the prescription drug attempts to control and regulate prices, PBMs and the wholesale acquisition price debate, and that testimony is very helpful. We might ask some questions about that going forward, but I do think that Senator Weeks has a question.
I do have one question. Thank you for your testimony. I'm curious, given the states which have boards which are dealing with prescription costs, one question is, have there been legal challenges in those states like Colorado? You mentioned Colorado, Washington, et cetera. And then second, have they actually realized savings? And if those savings can be quantified, that would be helpful, just to see if all this effort nets the desired result.
So, no, there have been no legal challenges. And the way these things are designed, there probably will be a legal challenge, but in my view, that it's unlikely to be successful. And we have several Supreme Court cases that are decisions that relate to how a state would operate, do statewide rate setting around prescription products and things. So, it feels pretty solid on the legal front, I will say, and there have been no lawsuits. And then there are no cost estimates yet because states, well, for instance, Colorado decided that the product that they looked at did not produce, did not pose an affordability challenge. And so they put that aside and they're looking at others. And so we'll see cost estimates, savings estimates when they make a decision that a product is creating an affordability challenge and think about setting up an upper payment limit. Obviously, then the numbers are going to come into play there. But in terms of producing savings estimates, we haven't seen them yet. I expect to see them from Maryland very soon because they are supposed to be presenting a plan back to the legislature, part of which includes savings estimates around some hypothetical parameters.
So the savings outcomes are currently a model. They're modeling those savings?
Yeah, because you have to you have to just sort of pick products and then sort of pick what you think an upper payment limit would look like. You have to just make decisions about many things. So they really are very sort of hypothetical estimates, if you will. So Maryland went ahead and produced an estimate looking at what Medicare, the drugs that Medicare has chosen to negotiate over, which they are doing right now. And so Maryland said, well, assume you save 3% on these 10 drugs in our state employee plan. And they produced that. But it is a number and it is an estimate.
That helps, thank you. Senator Gulick has a question.
You mentioned that the amount the consumer is willing to absorb or take on. Just for my own clarity, the consumer, is that the insurance company or the actual person on the street who needs pharmaceuticals?
It's the consumer, the person at the pharmacy counter or in the doctor's office.
Thank you.
So I have a question about that. Obviously, a lot of the boards are new and still getting into, getting their feet on the ground. But is there any indication that looking at specialty drugs and the cost of specialty drugs is going to add restrictions to folks who actually need them? So, for example, folks with significant arthritis concerns or other chronic illnesses like lupus, is there any access issue related to cost control?
Well, there should not be. The point of all of this is to improve access, make drugs affordable, sell more product, basically. And there is a lot of money in the system right now. Manufacturers can tell you how much discount they provide to payers and PBMs and rebates and things like that. There's a lot of money changing hands in a non-transparent way around these products. And even if some of the rebates just became on invoice discounts, for instance, it's actually no change to the manufacturer at all in terms of the manufacturer's net revenue from the product. But we've turned it into a discount in the supply chain so that when it gets to the pharmacy, it is a lower cost product, and the co-insurance, the deductible, whatever the patient has to pay at that point for their insurance, it's a much lower priced product.
Yeah, thank you. Because I've had communications from organizations, a national organization that has had the concern that I just asked you about. But
yes,
thank you. Yeah. So.
If a manufacturer would really have to choose to boycott the state.
Okay. Other questions? I did have another one, and I'll save it for later. Oh, I do have another question. So obviously we have PBMs and we have all kinds of, we have structures that theoretically reduce costs of prescription drugs to consumers. And one of those is through our 340B program. what, if any, consideration is being given to the 340B program when these boards are going into place? How are those being handled, either legislatively or practically when the boards are in place?
So, yeah, definitely there are concerns there on the part of entities that participate in the 340B program. And I think it's fair to say that no board is going to be designing or putting together a UPL that is as low as the discounts that these entities get through the federal 340B program. So, because those are very, very deep discounts. And so they're still going to be making margin on these products, basically. And the boards are not going to be putting UPLs on thousands of products. Every product on the market is in the 340B program. And I don't think a board could do more than 5 UPLs in a year, honestly, because there's a lot of research and work to support a decision, basically. So it's not a quick process. So it's a small number of drugs, and their discounts are still going to be substantially below what an upper payment limit would look like.
Okay, so thank you. No, thank you, because as we hear testimony, it's important that we understand that the goal is to reduce costs for the patient and to maintain access to specialty drugs, whether cancer drugs or whatever else they are. That's an important kind of baseline for us to understand.
Exactly.
And then the measurement of cost savings will be something that we're all interested in.
And also just to say, so nothing about how a 340B entity purchases their drugs, their particular supply chain, and all of that, none of that changes, absolutely none of it. And the other thing to put on the table is that nothing changes about the Medicaid program and the Medicaid rebate. If you had an upper payment limit in place, what would change is the pharmacist's costs. The pharmacist is procuring at the upper payment limit and billing at the upper payment limit. In reality, they're going to procure a little bit lower than the upper payment limit, but they're going to bill Medicaid at the upper payment limit. So, but the federal rebate, that formula, that is all federal, and this does not affect any of that. Only lower claims payment costs.
Thank you. And one more question from Senator Williams.
UPL?
Sorry.
Okay, can you explain UPL, the acronym?
Upper payment limit.
Okay.
It's a payment rate,
Yeah,
upper payment limit. I'm so
340B.
sorry. I apologize.
Okay.
I'll tell you. Okay, so why don't we have Mariana come on and we'll listen to your testimony. Welcome. Thank you, Jane, very much. Mariano, thank you for being here. Why don't you introduce yourself for the record, and then we'll hear your testimony. And we have your testimony on screen, so introduce yourself for the record and we'll listen.
Thank you so much, Chairwoman Lyons, and thank you to all the members of the committee. Can you guys hear me okay?
Yes.
Wonderful. I'm Mariana Soquel. I'm a physician. I have a PhD in healthcare systems, and I am an associate scientist at the Johns Hopkins Bloomberg School of Public Health. My research addresses primarily prescription drug prices and affordability in the United States. My research has found that on average, the United States pays between 3 and 4 times higher prices than other countries for the same exact drugs. It's not for the new drugs that are recently launched that we pay the highest prices. It is, in fact, for the oldest drugs in our market that we pay the most as compared to other countries. Comparing to the United Kingdom, for example, every year that a drug is in our market, we are paying on average 33% higher prices over time than in the United Kingdom. And why is that? Well, number one, other countries have mechanisms to bring prices down. In this country, we rely on what is called the market-based system to control drug prices and drug costs overall. The market-based system relies on the entry of competition, for example, lower cost generics, lower cost biosimilars. When these products come in, we have pricing pressure and we all have price reductions. The problem is in certain cases, we do not have competition coming in. Some drugs have been extremely successful in employing a series of strategies such as additional patents, changes in the product, pay for delay agreements, and so on and so forth. And some drugs have been successful in extending their period alone in the market as a monopoly, sometimes decades after the original market protections were supposed to be ending and competition was supposed to be coming in. When these cases occur, the lack of savings, the lack of that pricing pressure affects really everyone, consumers, healthcare plans, providers, and so on. But I would like to point out to two distortions in our market that primarily affect consumers. The first distortion is the lack of price transparency. The way that our market negotiate prices today is the manufacturer is the only entity that sets the price. The manufacturer in the United States is the only entity that determines how much a drug will actually cost today. So the manufacturer announces the price, that's called the list price, and it's the price that the manufacturer set. But of course, we have insurers and pharmacy benefit managers working on insurers' behalf that try to lower these costs typically through discounts and rebates that get negotiated. The final price that gets negotiated on behalf of health insurers and that health insurers will ultimately pay, it's called the net price. And that's confidential, nobody knows. Often, not even the insurer themselves know because these prices take a little bit of time to get calculated. So here's how it works. The patient goes to the pharmacy today and they pay over the list price. That's what's happening during the time of drug dispensing. Later, typically a month, at the end of the quarter, sometime later, the manufacturer will make a calculation and say, all right, this is the amount of rebate that I'm going to send back in the form of a check back to the insurance plan. And that rebate is the one that really lowers prices. But patients do not have access to that. So how does that harm consumers? It harms consumers in a series of situations. Number one is if the consumer is uninsured, they don't have access to any, of these steep concessions that happen later. Number two, if the consumer is in a deductible phase, especially in a high deductible health plan, that in that situation, the patient is liable for basically the entire drug cost. Or if their plan does not cover the drug, that's the same situation. But now the trickiest situation is when the person actually has insurance, has a general insurance. The insurance covers the drug, but the insurance requires the person to pay a percentage of the drug cost. This is very common for anybody who has a chronic condition and needs a high-cost drug. Often patients are requested to pay 20% or 25% of the drug cost. Well, that percentage is calculated over the higher price because at the time of drug dispensing, like I said, it is simply not even known how much the final price will be. And we all know that it never gets publicized and nobody really knows it. So the lack of transparency is one of the reasons why even fully insured patients today can have difficulty affording the drugs that they need. The second distortion that harms consumers, and it's really tied together with the lack of transparency, is the fact that every single intermediary in our pharmaceutical market today can make a profit off of these price concessions that get negotiated from the high list price to bring the price down. So even the insurer, the pharmacy benefit manager, sometimes the pharmacy, everybody can make a profit. So there is a benefit in some ways to having that lack of transparency. And in many ways, there's not a real incentive for the actual price to be known and to be brought down. Well, taken together, we have the system that is detrimental to consumers and can result in some cases in the consumer paying more than what the final price of the drug will be. I'll give you an example. If the consumer is paying a 20 or 25% co-insurance and that's calculated over the fully price of the drug. If the manufacturer later gives a 90% rebate, passes 90% of that cost back to the insurer, the patient will be, in effect, paying more than the final drug cost. And the insurer will be making essentially a profit off of that out-of-pocket cost that the patient paid in the pharmacy for their drug. Now, not every single drug has this problem, and that's why drug affordability review is important, because we need to differentiate the good cases from the bad cases, the cases that do represent a problem from the cases that do not. But I can tell you it is a frequent situation, because that is the model we use for these highest-cost drugs, and that is also the default coverage. The percentage co-insurance is basically a default in the Medicare program for any drug that costs more than $800 a month. And we know that commercial insurers pretty much follow the same standard. Having the authority to implement prescription drug affordability reviews is a critical step to, number one, improving transparency. Finally, one would know how much the drug really costs. Number two, creating the upper payment limits, which are payment maximums. They do not change the price that the manufacturer is charging. They change the amount of the flow of funds that will go in the supply chain, like Jane mentioned before. And it's a maximum. I mean, it still allows big players, big plans, big PBMs to negotiate for even lower prices if they can and want. But it brings a series of protections to the consumer. It protects the consumer from the volatility of prices that only go up in this country. It provides this transparency. It protects consumers from having the plan make a profit out of their out-of-pocket payments. And, you know, at the end of the day, it helps patients pay for their drugs, afford their drugs, benefit from the clinical effect from those drugs, and save money for all of us in the long run, you know, from acute and long-term complications, from the lack of drug access that we all know will send patients to the hospital, will create long-term complications, and, you know, tend to just increase costs over the long run. So Vermont, we know that other states, like Jane mentioned, already have chosen this strategy as an important component in the effort of lowering costs, especially to consumers. And I believe that Vermont would do an important step towards the same direction to protect consumers if the same authority was to be implemented. Thank you. I look forward to your questions.
Thank you. That was really terrific and comprehensive. I mean, the pricing, lack of transparency in pricing has always been such a significant concern, and especially when you're at the counter trying to pay for a drug. So, questions, committee. Got an expert here with us. It's your understanding of about boards, as Jane Horvath indicated earlier. What is your understanding about how the boards are functioning at this point, and any perceived savings that are going to that they will see? I know it sounds like there are only a few drugs that are going to be looked at each year, and so I think it sounds like there'll be the very high cost specialty cancer drugs or other drugs. And do you have any understanding of what's happening at those boards with specific types of drugs and accessibility and cost for the patient?
Well, it is truly a laborious process, right? Because in order to fully understand the affordability problems, the boards have to unpack, right? For each drug, how is that drug on average impacting consumers? How many consumers can or cannot afford it? What is the price that the insurer is actually paying? How does that compare with what patients are paying? So it does require, you know, a laborious effort to go through the core drugs and to target the most important drugs. So there's also an element of prioritization, you know, that goes into this. I'll give you an example. In certain cases, a board may choose to prioritize a drug that overall has a very high budgetary impact to the entire system because a lot of individuals use that drug and it is an important impact. In other cases, maybe it's a drug that is more rarely used, but those who use it have a real challenge in paying for it, you know? So the criteria that each board will choose may vary, but from my perspective, it doesn't matter what criteria we pick. We unfortunately have so many, the problem is so pervasive. It reaches so many different drug classes and categories. We go from diabetes to allergy, to oncology, to autoimmune conditions such as rheumatoid arthritis. And according to the drug that the board picks, perhaps it's possible that the plan may not have significant savings if they are already getting an 80–90% of rebate on that drug. And if that type of drug is chosen, it's really the patient that we are protecting. If a drug is selected where the case is that they were so successful in hindering competition that they have been able to keep prices high, then the board will be really helping even the plan obtain more savings than they could have. Because in this case, the tools that plans have to negotiate, they are not very successful. When there are no biosimilars, when there are no generics, plans really cannot do as much to negotiate prices. And a board could use that way in the calculation of upper payment limits to help distort that other market problem.
Well, thank you. I mean, it's just a struggle to get information to make those decisions within the state. So I see, Jane, you wanted to make a comment, and then we've got 3 senators waiting to ask questions. So go ahead.
Yes. That's why it's so hard to make an estimate, because the drugs are also different, right? And the economics behind them, making an estimate is almost like arbitrary, and people are uncomfortable doing that. Do you know what I mean? Like just deciding this.
Yeah.
So it would, as part of the process. The other thing I would say too is that for a state like Vermont, for any state, you can look at what Medicare is going to do, and I would also strongly recommend that a board take whatever Medicare does, their final negotiated price, and make that the statewide upper payment limit for that product. In other words, leverage all the work that the feds have already done. And we're going to start to see what those negotiated prices are, and then it's going to be much easier to start thinking about how much savings. So I apologize for interrupting.
No, that's helpful. Thank you. And obviously the Green Mountain Care Board is sitting in the room, so should this go forward at some point, then they're getting, Julie's getting all this information. It's great. Senator Weeks.
Thank you. So thank you for the testimony. It's, I'm really finding Dr. SoCal's testimony to be quite compelling. But a question for you. So I would like to go back and poke at why the market forces aren't having the desired effect in the U.S., as you were alluding to. In particular, the expiration of patents and the resulting effect on prices.
You know, I don't think manufacturers tend to use only one strategy. They tend to use all the strategies at their disposal to expand their monopolies. Patents are definitely a strong one, because in our country, we basically allow manufacturers to keep adding protections on any additional, pieces of change. Sometimes they can tweak, a method of administration, or, for pills, they can make it immediate release, extended release. With the case of Humira, which is a blockbuster drug, it's a $20 billion per year drug worldwide, has stayed in the US market from 2002 to 2023, basically without any biosimilars. Humira created formulations that were without one additive. At the very end of their patent life, Humira had over 250 patents in total, expanding their monopoly for well over 20 years. And all of us in this country were paying the high price when Europe had biosimilars for several years before we could get access to them. So it's this, in addition to the patenting, there's also what's called the product hopping. So they create, another example is Neulasta, is another high-cost biologic drug. Typically, it was injectable in the clinic. And then just a few years before it was going to lose patent and have a biosimilar, they already knew the biosimilar were coming. They newly created, of course, they already had it in the pipeline, but they were, the timing was so right. They released an auto injector. Now, which patient will want the injectable biosimilar if they can have a more expensive but more convenient auto injector that does not have a biosimilar, right? So these strategies together, they have succeeded in keeping these prices for these drugs extremely high and keeping competition at bay. Either the competition cannot launch, or if they launch, sometimes they struggle to get traction because the old product got a new version that is supposedly better.
If I can follow up first, can I make a comment that it's probably inappropriate to be cheerleading inside a committee room? If I can make that comment from advocates.
Okay.
Anyway, I'll make that comment and let it pass. So can we go back, if you can, that wasn't a comment for you, Doctor. If a patent, you use the example of Humira. If Humira has 100, 200, 250 additional patents associated with it over its life as it enters the expiration of its original patent, why can't a competitor pick up on that original patent and begin to produce the original substance, the original drug, and then in time add the benefit of the other 250 patents as time moves forward? What's inhibiting a competitor from reproducing the original drug?
Competitors have been trying to do that. They have been. We have seen that in the market. I've been working on this topic long enough to remember, 7, 8 years ago when the biosimilars were first, started to come into the pipeline, there was a lot of skepticism that the biosimilars market was never going to take off. But the truth is that manufacturers did try exactly what you are describing. And in many, many cases, their efforts were hindered by litigation from the branded product manufacturer. So they were developing it, but they could not bring it to market because litigation was delaying. There was a huge part of the strategy with Humira. Humira used litigation heavily against their competitors over time. And, it's just one drug we are naming. It is a problem with other drugs as well. We're just using that as an example.
That's a good example. Thank you.
The other thing I would just say about that is sometimes the originator manufacturer will make their product very, very difficult to get a hold of. And you need that original product to test against to show the FDA that it works the same as the product, the original product. And so this was a problem a while ago, and the head of the FDA said, I think in 2018, that he would allow imports of drugs if the innovative manufacturer wasn't going to make their product available enough to do clinical trials.
Wow. Okay. Senator Bullock had a question, and then Senator Hurry.
Comment, question, whole bunch. As a new senator, sadly, I find myself often in shock and disbelief when I learn things in this building, and I'm having one of those moments right now. Disbelief and shock that we tolerate this in the name of the free market. It is it's disturbing, to say the least. So I really appreciate what you brought us today. I don't see any cheerleading in the room. I see emotion, which is absolutely appropriate. My question is, it sounds as though fighting against this tide is very labor intensive, and I'm wondering what you've seen with your boards around the country. Have they had enough resource, enough staffing to be able to get this work done? And it's a question that I'll ask of the Green Mountain Care Board. Do they have the resources to do this heavily labor intensive work? Thank you.
Yeah.
Good. Yeah, we'll take testimony on that.
Okay.
Good, yeah.
So
Do you want to comment on the cost involved in doing this?
most of the boards are actually small, and they get a surprising amount of work done, even with a very small number. But they rely on people like Mariana, whose research is all focused on this and can help. People at Johns Hopkins are helping these boards. People at Harvard are helping these boards do the sort of the analytic work, like finding all the prices and things like that, and putting together the information for the board staff and the board members. So far, it has worked like that, and it has worked well. These supportive organizations have been very supportive. And then, so for instance, Washington State, as I said, is getting it together now. They're going to rely a lot on the information, for instance, that Maryland and Colorado have already produced. So people are trying not to reinvent the wheel and to be really smart about resources.
Thank you. Okay. Senator Hardy.
Thank
Go
you,
ahead.
Madam Chair. Thank you, Dr. Sokol and Ms. Horvath, for your testimony. It's really compelling. I'm wondering, I've been looking at the bill, S98, our proposed legislation, and wondered if either of you had comments about any changes we should make to the language to ensure that it's tight enough and adequate enough to do the work that would be necessary, especially when I found it really interesting, Dr. Sokol, your comment about it's usually the older drugs that are the more expensive in the end. That was surprising to me. And so I want to make sure that the language is sufficient to be able to capture that, and wondered if you had suggestions.
Well, thank you for that question. And I, very candidly have to admit that I was also surprised when we got that result, in our research, because it's something that we just assume, we make this assumption intuitively that prices would just go down over time. And that's exactly not the case. I think the important element in the bill is to, I am always a little wary of specific dollar thresholds. I know they are important, but because, like Jane said, the prescription drug market is often filled with nuance and detail that can, every single drug is different in the strategies that they employ, in how the pricing gets transferred or shifted to the patient, etc. So I appreciate that there is language there that goes beyond just dollar thresholds into also the possibility of other drugs that maybe don't not necessarily meet the dollar threshold, but they do have serious affordability problems. And I think that is a special case, for example, to allow for new therapies. We don't have a problem yet, and new problems that can come up in the future, special populations that may not reflect the experience of everyone, but they can pose a specific problem that the board may want to address. So I appreciate that. And I would also make just as a consideration that this case where patients are paying more than the final price. So basically the patient is over the title of a co-insurance, the patient is actually paying in excess of what the insurer is actually due to pay the manufacturer. And it does offer an opportunity for revenue, in fact, for the insurer in that situation. I think this is an important and a special case that might be of particular interest.
Okay, that's very helpful. I will note that for when we go through the bill together. Thank you.
Thank you, Senator Weeks.
Just a quick question to follow up. Can you give any percentage on the patients paying in excess of the actual cost of the drug? Is there, is it 5%, 1%? Just something to kind of, what scale are you?
Unfortunately, I think this is very common because, for example, if you take a generic drug can cost 50 cents, but my copay is $10. So I'm definitely paying much more. I just don't think that in these cases, that's an important and damaging and hurtful situation for the consumer, right? So if we're just taking frequency, it is something extremely frequent, but how frequent it is that the actual cost is so high that, we are involving high cost drugs, that depends on the high level of rebate. And it would involve drugs with, at least 80 or 80+% rebate. The last time I checked, we had about 30 to 40 drugs in that category. I think the data was from 2023. I did not publish this data yet. It's just an exploratory analysis for one of my papers. But the small number of drugs doesn't mean they're not important, because some of these drugs are top spenders, right? We're talking insulin and other drugs. I mean, just in the Medicare negotiation program, it was 10 drugs, but they accounted for 20% of the spending. So I wouldn't be, discouraged by, quote, only 30 to 40 drugs, because some of them are very impactful budgetary wise.
Good, that's all.
Yeah, good, thank you. This has been really very rich with information, and we greatly appreciate your being here this morning. We're going to move on to our healthcare advocate at this point, but I would ask each of you if you might be available at another time should we have follow-up questions.
Anytime.
I'll be available and happy to help. Please let me know.
Thank you so much. I greatly appreciate it. And we're going to finish. We're going to take testimony and finish up in about 10 minutes or so, but you're welcome to stay on. And if you would like to make comments, just let us know, because I think it sounds like we're interested in this bill to move it, keep learning about it. Okay, so
Good morning.
welcome.
Good morning, Mike Fisher, healthcare advocate. And I just want to also recognize, recognize that the goals of transparency, affordability, access, and consumer protections in the realm of prescription drugs, despite a lot of efforts, have been elusive. It's been hard, and the Vermont legislature's worked at it for a while, and so I want to recognize that that there are passions in the room, I think, but I also think good call. I think the witnesses in the room need to manage themselves. So if I may not have done that. So in which case I apologize. The HCA, the Healthcare Advocates Office, supports this effort. We have to try everything available to us, and this seems like a potentially successful and useful tool to protect Vermonters. So general support. One comment about the statute that I would welcome comments from the experts is, there may be two opportunities that have already been mentioned by the experts before me, and that is to piggyback on the national Medicare negotiations, and also looking to, I'm not sure the second one was said, is clearly looking to other states' previous work to build upon their work. And I wondered whether the statute could direct the board to do some of those low-hanging fruit first, or recognize those opportunities. And then I also have to recognize that this does not look like a small minor task. This looks like it would certainly take some staff resources. And as I said, testifying about another bill, I spend, and my staff spend, a great deal of time watching the public activities of the Green Mountain Care Board and working with staff at the Green Mountain Care Board. We think in order to do this, we have to, if we're going to do it, we got to do it right. We got to support them with the resources to do it right. I know I'm not saying anything that you won't hear from others. And then lastly, you have given the healthcare advocate a specific statutory role in pretty much everything that the Green Mountain Care Board does. We have a statutory role in certificate of needs, and hospital budgets, and ACO budgets, and insurance rate review. I think we would look for similar language about this if this idea is moving forward.
Good idea. Questions? Senator Williams?
So I'm looking at next level up. It sounds like part of the problem is the manufacturer not releasing the patents. Is that something the federal delegation could, I mean, there's not much Vermont can do, obviously, except, you know, because we're very small, we don't have a lot of competition, but, you know, I've dealt with the automotive industry where we've got a problem getting parts because the manufacturer hasn't released the patent yet.
Yeah.
And then other companies can manufacture that. That would improve competition if they would do it.
So I just want to recognize you're asking the wrong witness that question.
We'll have to decide how to answer that question. Maybe we'll go back to our two expert witnesses and get a response.
But I do want to make sure we have time. I didn't say it at the outset. We also do have a proposal of of an initiative that we think fits well in this bill. And I have a staff member, staff attorney from my office, Charles Becker, with me, and I'd love to turn it over to him to describe the.
So why don't, if it could be like very quickly, because I want to give the committee a break before we go down into agriculture. So why don't we do that?
Yes, thank you.
Welcome.
Hello, thank you very much.
Why don't you have a seat?
Sure, absolutely. Thank
And
you.
then introduce yourself, and we'll introduce ourselves because I don't think you've been in our committee before.
No, I have not. So I'm
Okay.
Charles Becker. I'm a staff attorney with the Office of the Healthcare Advocate.
Senator Brewer.
Oh, hello. This is my own little world. Martine LaRock-Ulick, Senator from Chittenden Central.
Nice to meet you.
Good morning, Dave Weeks, representing Rutland County.
Ginny Lyons, Chittenden Southeast.
Terry Williams representing Rutland County.
I'm Ruth Hardy from the Addison District.
Very nice to meet all of you, and thank you so much for a little bit of your time this morning. I got this down to 10 minutes yesterday. I'm going to try to get it down to 5 or less.
Well, I was going to say, if you give us some information today, we will have questions, I'm sure. And this is a new topic for us, so
Sure.
we might have to reschedule you another time when we're looking at the bill. So just the high level view today, and then I think we'll come back to the full slide presentation.
Okay, so let me just give you a high-level overview then.
Yeah.
So the words up there on the screen are copay accumulator adjustment programs, and those are, can anybody make sense of what that means? A copay accumulator adjustment program is when an insurer decides not to count the value of a manufacturer's drug copay assistance, so a coupon card that a patient brings to the pharmacy counter and says, I'm faced with a very high deductible here, a $1,500 copay to be able to afford this medicine that my doctor has told me I need to maintain my health and to live a healthy life. In order to afford that medicine, I need help from the drug manufacturer. And we've seen the ads on the TV, right? If you can't afford your medications, call the drug manufacturer for help. Well, that's what this help is. It's coupons, right? And when you present that coupon to the pharmacist, the drug manufacturer helps the consumer and pays that copay for them, right? And the way this was working for quite a while was that that copay assistance was counting towards a patient's deductible and out-of-pocket maximum for the year, which was an incredible amount of help for a person with in many cases, a chronic illness or a rare disease that costs a lot of money to manage. At some point, insurers, PBMs in particular, decided that there was a way to extract that value for themselves, and that was to implement what are called copay accumulator adjustment programs. And what they do is they adjust out or subtract the value of that copay assistance from a patient's copay accumulators, how they keep track of your copays that you make throughout the year. So you present that coupon at the pharmacy counter, say it's worth $500. That used to count towards your deductible and out-of-pocket maximum. With a copay accumulator adjustment program, they subtract that $500 back out and you still owe it again. So you really don't get any benefit from the drug manufacturer's copay assistance. And this is a huge problem for people with chronic illnesses and rare diseases who require very expensive medications. We've heard today about all the great expense. You know, we have the most expensive drugs in the world, you know, and so these programs, take these programs away from patients is not right? And so I'll just skip ahead to the very end of my presentation. You can see that there are 19 states that have banned copay accumulator adjustment programs. You'll see that Vermont is not shaded blue. And we are proposing that we add Vermont to this list of states.
So this is a good suggestion. This is different from the bill that we're looking at, but it's certainly something related. And what I'm going to suggest is that we allow you to have more time and to bring you in when you can fully explicate and present your slides. Because it sounds like something we will be very interested in for consumers.
And I would appreciate that opportunity.
Yeah, so let's do that.
Okay.
I appreciate that this is a new part, a new section that might be added onto the bill. So let's have you come in, and we appreciate your time today.
Thank you so much.
Yeah, no,
Yeah,
this is
I'll come
terrific.
back.
We don't want to lose this good information.
Can I just one very brief statement, fair disclosure, we are also promoting to have this same language in a version of a bill that's working in the House. We think it makes sense to put it on this as well, and happy to come back.
Okay, we'll have to chat about that, but we do want to learn about it, so we'll have it back
Absolutely.
in. Okay, thank you.
Thank you so much.
Yeah, that's great. All right, so we're at the end of S98 at this point, and we're going to be in the education room.
That's gonna be a tight squeeze in there.
It will be, we're going to sit around live.
Oh, we're physically going.
Oh, I guess
Okay.
no, because it's the ag committee, not the ed committee that
Yes.
we're going with, yeah.
Same
We're
room.
going in.